Hey, Z-Pack, I have a special guest today. We're really excited because we're going to talk about how we can kill less people, harm less people, and actually look deep inside and see what we're doing in a way that we are unable to do now as clinicians.
Yes.
Nurses and everybody, they already know kind of the care variation in this country, how some doctors are better than others. But the thing, you know who doesn't know that are doctors. And I have with us today Dr. Bill Rifkin. He's an internist, used to be a program director at Albert Einstein, is the managing editor of MCG Health, and he's here to talk about this stuff. Bill, welcome.
Thank you. Pleasure to be here.
It's interesting. So, like, we'd connected on a phone call, and I expected to hate you. I'm going to be honest, because in this show,
I get that a lot.
Yeah, it's something about you, man. Right. No. It's because you're talking about guidelines, about measuring variation in care, about what I like to call the measurement industrial complex,
yes,
which
yes.
we've been clicked and measured and cookbooked into cookbook medicine.
Absolutely.
And so it triggers a lot of frontline docs to go, wait a minute, no, I don't want this in my life. I need autonomy. But when we talked, I increasingly found myself cheering and rooting for what you were doing because you have nailed it, which is we don't know what we don't know when it comes to care variation. How somebody in Texas practices completely different medicine than somebody in New York. Mm-hmm. But yet we actually have data as to what the right medicine is.
Right.
So tell us where to think about this even to begin with.
I often am put before docs who they start off, I might have like 2 strikes against me already because you're coming from this guideline place and you're going to tell us we're doing something wrong.
Yeah.
So it's not a very good conversation.
Triggered
right off the bat. Usually when they actually either see what's in the guidelines or what the data is, they are much less threatened because it's clinically reasonable and it's not black and white and cut and dry. There's very little in medicine that is like absolute, like this number means you need to be admitted, this number means you don't need to be admitted. And it's a very difficult situation the doctors are in because they have to justify their decisions for a payment mechanism, which requires them to do more documentation than they had ever done before, and to basically show their math a little bit. Of, what made you say the CHF patients need to be admitted, not just pulmonary edema, diurese, admit. And then there's been this added new thing of observation care, which we were all trained. It was admit, don't admit. Yeah. And now it's admit, don't admit, or should I put them in observation care, which might end up as an admission or not. So rightfully, the docs are either confused or have heard the wrong thing, and they need some guidance, but it's also like a frame shift. A lot of the situations that were slam dunk admissions, when they train. So CHF comes in with enough pulmonary edema to be hypoxic.
Right.
Used to be, oh, that's an admission. Easy.
Right.
We call the residents who needs the admission. Now, not necessarily.
Right.
Not necessarily. It depends how they respond to initial treatment.
Well, so again, I find myself being drawn into this conversation because as a hospitalist, you're a hospitalist as well. As the measurement industrial complex started interfering with our autonomy, and that's how we felt about it, they were telling us, okay, no, this is definitely an OBS, and you screwed this up, and now the hospital doesn't get paid, and it's on you.
Right.
Or you clicked the wrong boxes to show that the CHFer needed to be admitted. But in the background, what's happening is our entire care paradigm is changing. We no longer have to admit a pulmonary embolism if we can get them outpatient, anticoagulation, and they're stable. But so many doctors are still practicing either back here, and we don't have mechanisms to even compare ourselves to other physicians.
Right. Actually, PE is a great example.
Yeah.
The study's a little bit old by now, but there's this great graph of what percentage of PE patients coming to one of 500 EDs is treated as an outpatient. And the curve is like this. So there's, maybe an eighth of the EDs that read the study, and it's like 15%, maybe it's even too high. And then there's a third of the hospitals, the number is 0. They never heard of it. Yeah. They never considered outpatient treatment. And probably all the docs in that hospital are practicing similarly and all think they're doing the right thing.
That's the thing. We don't know what we don't know. And people are like, trust your doctor, they know what they're doing. Oh my God, Bill, I've looked at your data of care variation across the country.
It is
terrifying. The number, just take a bariatric surgery. So surgery to lose weight. if you look at the best surgeons in terms of outcomes, quality, et cetera, they're following guidelines, they have at a center for excellence, compare it to somebody in the community that's doing bariatric surgery. The difference is that person in the community needs to treat 11 people to have one extra person die from a complication.
Yeah. I mean, some of the real shame of this is also, why isn't this more common? So there was this great study with bariatric surgeons where they actually did, all the surgeons in Washington State made a tape of them doing the surgery, lap sleeve.
So they videotaped them doing the surgery.
Videotaped them doing it, or the key part of it. And they sent these tapes to other surgeons who were trained, and their ratings were similar to each other, and they rated the people on a curve of skill, actual surgical skill.
Who was rating them now?
Other surgeons.
Other surgeons, so just a mix of surgeons.
Yeah, but a group that was trained to evaluate, and it's, you know, if I said it was good, he's likely to say it's good.
I see. So they're a little higher level in terms of,
And their ratings correlated with complications. So it was very interesting that there's even a study like this, and yet this is very rare. This is notable because this study exists. It's very rare.
So let me just rephrase this, because I think this is the most important thing that we can say today. There is data that shows that an independent panel of surgeons can review different surgeons' procedures, and what they determine, oh, that was appropriate, that was not appropriate, that was good, that was not bad, that correlates directly with the number of complications that surgeon has. In other words, we have a known and proven mechanism for evaluating surgical technique, yet these surgeons vary in their abilities, are allowed to vary in their abilities, and patients have no effing clue which surgeons are better than others.
And it's not just surgeons. I mean, surgeons.
No, it's I like to pick on surgeons because they like to consult us as hospitalists.
They always make fun of us, so we take
have to go back.
anytime we can do. They actually do something. We just
I'm actually quite jealous of them because they do stuff. Steel heels.
We're still rounding.
I know you were still rounding, talking about gout, and they're actually removing somebody's spleen.
Do you know the Romans? Yes, I know they had gout. But so it's also true in internal medicine, internists as well. I guess the basic thing is most patients are not in a position to evaluate if their physician is good or not. Because they judge them on their manner. I actually even saw in training that the docs who were well thought of and were like the leaders weren't always the best clinicians. They were nice to their patients. They basically did what their patients wanted them to do. So they were popular. They were popular in the hospital because they were doing things that brought in a lot of money. But we all knew they weren't the real best clinicians. And I guess once you're done with training, docs very rarely are actually evaluated on what they do, or their outcomes, or their decisions. Like, you know, do you admit more patients than I do? And why?
In a meaningful way. So we have maintenance of certification, but that's just a bunch of questions on a test that don't correlate to what I do as a clinician.
You have to do this right. I mean, because we've probably lost a few generations already where, you know, you're either measuring them by a bad measure, like I think readmission is a bad measure. So you're measuring them for something that's not in their control, or it's bad data. You're blaming them for patients. That wasn't my patient. Yeah, I admitted them, but I wasn't the one on day 3 to make the decision. Or you're just doing a whole group of, we'll evaluate the hospitalist group. But then everybody says, well, it's not me, it's him.
See, and then we feel powerless. We feel like we're being graded on things that are beyond our control. Like you said, we feel like we're being told to practice cookbook medicine when in fact there is nuance. So, but the thing is, there is a way to do this. And so, you know, you work with this group that creates some guidelines, some technology that helps us, but you get a lot of pushback from docs, right? So if you implement it at a hospital, they get very upset.
Often, I don't even know what percentage it is, but one of the roles I have is, you know, the C-suite bought our guidelines and they're rolling it out, and the case managers are using it, and then some of the docs are like, what is this? What do you know, somebody says, MCG gives you 2 days, you know, length of stay. Like, who's MCG and why 2 days? So then I walk in and say, hi, I'm from MCG. And I've actually been like cornered in the physician's lounge, you know, by 2 pulmonologists and their posse behind them saying, are you the guy who says all PEs are 4 days? And I'm like, me? No, we don't say that at all. You know, so it's misinformation. You know, the whole concept of a goal length of stay is some of the time it can be 4 days, and there's reasons it could be more that are perfectly rational, and then there's reasons that we all know are not rational, and, you know, are systems issues, and differentiating between the two is how a hospital can improve. But the first thing was almost like daring to measure, their length of stay. Because the first thing doctors say is not my patient, and the second thing they often say is, but my patients are sicker. So you have to prove with your data that the patients you're looking at are very similar to their patients.
Right, risk-adjusted data is important, because that's the thing that surgeons will say, you're reporting my complication rates, you're making this all public, I'm looking terrible because I'm the only person who takes these sick patients. But, can you adjust for that?
So there's lots of studies that have formally adjusted for it and still find these differences.
Right.
We can do some of that, and also some of it is we look at so many patients. So we look at so many heart failure patients when we say the admission rate is, 70% for Medicare CHF patients. We say that based on literally hundreds of thousands of patients. So when somebody comes to me and says, well, my patients are CHF are old, I'll say, well, actually half of our cohort is over the age of 75. And they have diabetes and they have kidney disease. So our patients look like your patients, certainly in broad strokes, to come up with reasonable targets and to show this data to people and say, this might be valid.
Well, so what's interesting to me is I think, and there's a little pushback I'll push back on, because what you're saying is absolutely true. We can do so much better. The nurses know that there's variation in care, and it's not good. They know the one doctor who does things well and the one doctor who doesn't do things so great, and one doctor who they would not send their dog to. They know this, but this is not public data. Now, where physicians are feeling beleaguered now and where it's hard is that, say a company like yours comes in and says, okay, we have this way to improve it, but you don't motivate the heart. In other words, there was this guy, you probably heard this story, Ignaz Semmelweis. He was a doctor in the 1800s, and we had the vitamin C sepsis guy on the show, Merrick, talking about this. He found that, wow, he did a study. If you
wash your hands.
If you wash your hands on an OB ward, the women don't die of puerperal sepsis.
I think they'd want to wash them anyway.
You would think. But back then they didn't know. The germ theory wasn't a thing. So the midwives were having these great outcomes and the doctors were not. So what happened? When he publishes this stuff, they fire him. He dies in a mental institution. Why? Because doctors, no one approached their elephant, their unconscious limbic system. They were defensive. They're like, hey, we can't be causing this harm. We're already beleaguered. They're making us do all this stuff. How can the nurses be doing better than us? And so we have to get, when I talked to you on the phone, one thing that got me was you made me feel something that, wow, we need to do better for our patients and for each other in terms of eliminating care variation, because we're hurting people. My mother, my father, if they go to the hospital, I want them to get the same good care across the system. And we're not doing it.
Actually, it has to come from, first of all, some doctors I've worked with are my heroes. So, it's sort of like the soul is good. It would be akin to a pilot on the East Coast. They fly a certain way, and the pilot on the West Coast flies a different way. And in a given situation, let's say there's a right answer. There's not always a right answer in medicine, but if there's a right answer, you would hope that as a profession, we would have, well, most people are going to pick the right answer, and if you're not picking the right answer, somehow that would get noted and fixed. We inspect pools, we inspect elevators. How come we're not noting that these things are happening? Because you're absolutely right that the nurses know. Remember, like when you picked up somebody's service, you picked up another physician's service. Some of them were huge because they never discharged the patient.
The rock garden.
And some of them are very small because they did. And everybody felt, well, my patients were different that month. Month after month, their patients were somehow different than everybody else's patients. And hopefully with the right data and the right approach, and certainly appealing to their, almost every doctor I've met wants to do the right thing, and it's sort of getting past the threat, and it's not like I gotcha type of mistakes. It's more just, gee, in your ED, a patient is literally twice as likely to be admitted than an ED over here. Maybe there's some differences in the patients, but not enough to explain all that. And that's been shown in study after study after study.
It's never enough. The differences are never enough to explain it. It's the practice patterns. And we all know this because if I pick up a service from Bill versus John versus Nancy, I know in advance what their patterns are like. I know Bill's going to be a rock garden full of over-testing and over-intervening. I know Nancy's going to be somewhere in between, and John's going to discharge them all early, and they're going to bounce back. By the way, these names are not made up, but the practice patterns are. And so the question is, you made the analogy of the airline pilots. You wouldn't want so much autonomy in your airline pilot that they're able to do barrel rolls. But you want enough autonomy that you have a Chesley Sullenberger who, when the cookbook flying.
We're off the reservation.
They were off the reservation. He has enough autonomy, critical thinking, and skills to go, I'm going to land this ish in the Hudson because I feel this plane. It is not going to make it to the airport they're trying to get me to go to Newark. So you need that. You need it in nursing. In nursing right now, they're just told, click the boxes and call the doctor. They used to think critically. And the older nurses they're burning out. They're being forced to retire, replaced with the new nurses that are just like click, 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 call the doctor, document, no thinking. So there's some gray area with cookbook algorithms and autonomy that we need to find.
Absolutely. I mean, good guidelines are flexible. You know, if some guideline, what I like to say is like, you know, I can't tell you how many ribs up the pulmonary edema has to be to admit a CHF patient. I can make up a number, but you can't be evidence-based, clinically real, and precise beyond the evidence. So you're going to use words like severe, persistent. What does that mean? Well, describe it in your note. You know, did they respond to treatment? So it's not removing autonomy. On the other hand, it shouldn't just be a blank canvas. A doctor shouldn't be able to do the wrong thing so easily. I mean, there's studies that are truly frightening. One that stands out to me is where they're measuring what patients got screening tests at what age. So, you know, a PSA for prostate cancer or a pap test for cervical cancer. There's a study looking at patients over the age of 65, and based on survey results, they can put them into like high risk mortality over the next 5-9 years versus low risk. And the difference in the screening wasn't very much, and people were still screening these very, you know, a 75-year-old who's really, really sick. They're still doing a pap test or a PSA on them. That either means it's just completely rote.
Yeah, you're just clicking boxes, right?
Or they're being measured by it somewhere and they just feel like they can't explain why they're not doing it, so they'll just do it. Or they don't know the math, and their understanding of a screening test and benefit in 10 years doesn't make sense for this patient.
It's crazy. And if you really look at it, and this is the thing, I've seen your slides of your data. I didn't put them on the show because I don't want to trigger a mass riot in this country, but if they saw the clinical care variation data and how much it's harming our patients, these aren't our patients, these are our loved ones, these are our brothers and sisters and our parents and our children that are being harmed. We never, you know, you and I are docs, we're hospitalists, we can build a wall around ourselves and not feel stuff. We're good at that. When you feel it, you just get upset. And you know, Jill Gambon says here, I think the word you're looking for is getting past their egos. Do you think ego is a thing, or do you think we're just conditioned? What do you think it is?
Well, part of it, I think, is ego, because, for example, there are situations where they want me to go talk to the people.
Because you're a doctor.
Because I'm a doctor.
Right. Deploy the Rifkin. Right, exactly.
Some of it is also just because I'm an obnoxious New Yorker, and, you know, if somebody corners me to talk about PE, I'll push back.
Yeah, I love it.
But, so some of it is just that culture thing, but some of it is, you know, it's a good thing that docs have confidence. You want a doc to have confidence. I think it goes too far if they are defensive and resistant. So if somebody comes up to them with valid data that says they're acting or their decisions are somehow at variance, significant variance over time from some other benchmark that we think is reasonable, that oughtn't be threatening as much as, gee, I better read about it or hear more about it.
It oughtn't be, but I'll tell you, humans work. You know, I mean, on this show, we're very much about how do you persuade other people to do the right thing. And a frontal attack using data when their belief is something different will fail every time unless you first form commonality, get an emotional connection. Maybe you use a little humor as a Trojan horse. And that's why I like you, Bill, because when we got on the call, you know, it's like, here we are, two doctors, we speak the same language, we don't take crap from anybody, we don't like administrators any more than anybody else, but yet at the same time, in our hearts, we want to do the right thing for patients. So motivating people, then you can use the data and go, look, Z, I bet you didn't know. And this is what you did with me.
Absolutely. Because also some of it, frankly, day in, day out, the way it's being presented to doctors is brutal. It's like denials. So meaning, somebody 6 months later looking at your chart says, I don't think they need to be in the hospital. And sometimes their reasons are right, sometimes their reasons are wrong, but you're already in that contentious, you know, you have to defend what you did.
And it's very unpleasant.
It's very unpleasant.
It feels like you're being attacked directly,
Right.
Yeah.
I mean, I guess the unfortunate reality, though, is that the only reliable brake in our healthcare system are the payers. I mean, so it's not the big bad payers. I mean, nobody else is saying, gee, maybe you don't need that total hip, total knee, whatever surgery it is. So unfortunately, the system we've fallen into is, you know, often the doctors are rightly or wrongly on board with a pathway. You know, this is either this is what they do for a living, or if it's a grade, it's a close call, they're going to err. You know, incentives work. I don't think it's a secret. So we've developed a system where the yes/no is coming from the payers, not from the doctor-patients talking to each other, or at least some of the time the doctor saying, I don't think this is the right thing to do for you.
Right. Well, you know, you see this. Okay, this is a piece that I think is fascinating. The payers, insurance companies, are the only actual people here whose financial incentives actually align with doing the correct amount of care. Now, they don't always get it right, and so their prior auths are onerous, and we hate them, and they deny stuff that based on bureaucracy. But when it's done correctly, they're the only people going, you know what? All the data says what you're doing is at variance. And we hate that because we hate insurance companies, right? So, and patients hate it because you're taking the doctor-patient relationship and you're interfering with it. Could it be that we could actually transcend that by not making it a payer? I know you have to do it now, but could it be that we could actually just have clinicians be doing the right thing because it's the right thing to do? You know, if they have the tools,
if they have the information at their fingertips, if
point of care,
if they really knew, like let's say this doctor who's ordering a PSA on a very sick 75-year-old man, if somewhere in the process they knew that this was an odd decision or something, would that help? There's even a study about that where they took patients who had either acute coronary syndromes or PE and vague symptoms that could be one of those in an ED. So
chest pain, shortness of breath.
And they randomized one set of doctors, was in their EMR, they had a web tool that, based on a Wells criteria or TIMI score, told you, gee, this patient is low risk for this. If you do a troponin or you do a D-dimer, you can discharge them. So, and then half the docs didn't have that tool. The physicians consistently overestimated the risk. So, like the tool said 76% of the patients, if you do this blood test, they can go home. The doctors said 30% of the patients are in that category, and they overestimated the risk so that they then had to get further testing. To me, that seems like a factual, like it should be relatively less threatening. It's a factual, this patient's chance of a PE is lower than you think it is.
Let me give you the counter argument that the docs will give. But if I get sued because this was one of those 1 in 1,000 where we miss it, can I rely on these guidelines then to defend me? And if the answer is no, then I'm going to overtest.
Absolutely. So I think the first thing is that a lot of the problems the doctors report are accurate. I mean, you know, I in my position, I'm in a very unique position. I hear horror stories from the payers. I hear horror stories from the providers.
I've been in that position too.
And they both have their
valid points.
They have their points, right? I think I never know what to do with the defensive medicine thing, because on the one hand, it's true. I mean, you know, you hear the horror stories of somebody who documented a conversation about the PSA, they followed 6 guidelines, and they did all this, and the guy sued him 10 years later because he got prostate cancer and was successful. I don't know if that's the tip of the iceberg, and lots of people are in that, or that was one case out of 10,000. Usually, my response is, you know, try to do the right thing for the right patient, and ordering extra tests, sometimes it might make you feel safer, sometimes it could be worse. You order that CT angiogram that wasn't necessary, and it shows a small pulmonary nodule that you didn't react to. And that becomes a problem in 10 years.
Or you're injecting dye and you box their kidneys. Actually, you know, and this to me is the fundamental nuance in this that I think we have to get better at. There is the malpractice, there's the litigious stuff, but there's also there's who's going to own the responsibility for it. So when these new PE guidelines came out, I was, as a hospitalist, I was ecstatic because I hated admitting,
just for heparin and Coumadin.
Heparin and Coumadin. It's like, this person doesn't want to be here.
Right.
They don't need to be here. And so this is what would happen. I tell the ER at Stanford, look, guys, like, this is a perfect example of somebody you can send home with the thing, and and have them follow up in our clinic, outpatient, because we're all integrated. We'll see them tomorrow. We'll get the INR. We'll make sure that, and they're high functioning. They can inject heparin, BID. It's perfect. And the ER doc would say, I'm not getting sued doing that.
Right.
Like you come down here, and you discharge the patient.
Yeah.
And you know what? I did.
Yeah, I'm smiling because I did the same thing. I bring my little posse of residents down, and I was angry, and I would do it, and I'm like, I hope that was the right thing to do. It felt very good.
It felt really good, but then
really good.
The back of your mind, you're like, you know what? Are these guidelines really that good?
Right.
How many people did they study? I've looked at the primary data, but maybe I'm just not smart enough to see the holes in it. Maybe this ER doc, who's 10 years my senior,
knows something.
He's
picking up a signal.
He's smelling something in this patient. But more often than not, it's not. It's just practice patterns. It's ego. It's fear.
I mean, patients patients and doctors, they both, you hear about the cases that go very wrong. So the doctors getting sued even though they did the right thing.
Right.
Studies are mixed on how much defensive medicine actually does contribute
That's
to the
right.
care.
They are mixed. Some people say 10%. Some people say it's not that.
Right.
Yeah.
It certainly sounds logical. Another variable, though, are the patients themselves. So in the New York area, for example, you try telling somebody with a backache that's not better in 3 days that they don't need an MRI.
Yeah.
Or for their kid's headache, they don't need a head CT.
Demands of the patients,
So it also becomes like a self-fulfilling prophecy. So patients in high utilization areas are used to certain levels of care.
Right.
Well, this is what happened last time, or the other doctor did it, but somebody has to start changing it. That's how we get these islands of variation, because they do it differently over here, but the patients are used to that.
Yeah, that's a key thing, patient expectation. And again, if I look through these comments, by the way, these comments are great. They're really appreciating this conversation we're having, because it's a conversation that a lot of people...
Most of my family?
It's all your family. Their whole last name is Rifkin. What's the deal with that? I think that, monitor and treat the patient, not the monitor. Treat the patient, not the numbers. And again, this has more to do with this is what I like to think of it as. You're evidence-informed, guideline-informed, but not evidence-enslaved. Right. You're not telling Sullenberger you cannot land in the Hudson.
Right.
You're saying
it's off the guidelines.
It's off the guidelines. Right. You use your judgment. This is where all your 10,000 hours of training. And I tell the story. Chesley Sullenberger. I saw he opened for me at a Kaiser conference Mid-Atlantic.
Wow.
So I had to follow this guy.
Follow that.
Yeah.
So
and you know who went
saved 500 lives like the other day, and you're like, well,
I'm like, I'm a clown on YouTube. It was literally like that. So he goes up and he does this thing, and he plays the tapes from the day that the FAA tapes, and that aren't public. And you're sitting there, just everyone, there were 1,000 physicians in the audience. They're all Kaiser docs, and they're listening just riveted to this, because they're putting themselves in that plane.
A situation like that.
Like that. And he's like, this is what happened. The birds hit the minute they hit the engines, you could smell in the cockpit the burning birds, and he says you feel it. It's nothing on the dial says
like
change
a stall.
But you feel the bottom drop out. Yeah. And he's like, it's the worst feeling, and for 30 seconds you're just paralyzed. You're just incapacitated.
Right.
Then everything you ever studied for, every flight he flew in the Air Force, everything, all kicks in. And the team, he has his co-pilots, he has the stewardess, the airline.
Everybody knows what to do.
Everybody knows what to do, and they all go into overdrive.
Right.
Here's where we violate the guidelines. Here's where we do the checklist.
Right.
And he lands the plane in the Hudson, and they play and he says at the end, he says, and so I want you to think about those 32 seconds on which your whole life is judged. And are you ready for it?
Yeah.
And when I think about what you're doing with care variation, this is how we should think about it, this emotional, intuitive truth that we can do so much better with a little technology, a little science, and a lot of heart and caring.
Absolutely.
And less ego.
Yeah.
And everybody was crying in the audience, and then I have to go up, hey guys!
Hi. It's also important for good guidelines. Also know that not every situation is about it has a guideline.
Yeah.
You know, so
Yeah.
yes, some patients with heart failure, pneumonia, COPD, but there's going to be exceptions. So I can imagine nothing could be more demoralizing than, a team does some, great work on a COPD, or they're intubated, then they extubate them, they make them all better, and then somebody comes by later and says, that was wrong, it was off the guideline. I mean, that would be, so guidelines could be misapplied, they could be overly ambitious in what they cover, but on the other hand, there is best practice, there is science, there is data about what can do. One of the ways I put it is I show some slides about variation, and I say, slides like this, you're the CMS administrator, so you have billions of dollars and you're spending it, and you see these curves of different care, different places. You're like, why is that happening? Isn't it the same disease in different places? And that type of variation, I think, makes it harder for doctors to say, like, I'm the doc, leave me alone. I know what I'm doing, I'm the doctor, leave me alone. That's the basic answer we have. And unfortunately, when you do that, you get this variation.
Yeah, so we need to let go of some of this 1.0 thinking. Now, the pushback will be, well, you guys are just health 2.0, you're the matrix and commodifying us. No, the way I think about this, and talking to you inspires me to think about this more. We have to optimize the ship of 2.0 so we get to the shore of 3.0, where we're able to spend time, repersonalize the relationship. True precision and unique person medicine means the guidelines and when to violate them.
Absolutely. Or guidelines have a recommendation. They're rarely mandates.
Cut and dry.
That's actually a plus and a minus. So in our content, for example, there are times where the evidence lets us say something like, this FEV1 number after this number of treatments means you should admit this asthma patient. There's evidence-based guidelines out there that we can cite. So you put a number out there. So then people will be like, well, so 1 above means admit, 1 below means don't admit. It's like, well, no, So precision can work both ways.
Yeah, no, absolutely. And the other thing you said that I want to bring us back to is, there are a lot of things in medicine where there is no answer.
Yes.
We don't have a guideline. We don't even have a clue.
Right.
And that's the sacred space where you and me talking in a room, you're a patient, I'm a doctor, or vice versa. That's where we thrive. And we can get to that spot by taking care of the stuff we know we have guidelines for correctly, so that our mothers and our fathers and sisters and our children are getting the same care no matter which hospital they go to. The other thing I think is we need more centers of excellence and less just random community hospitals.
Yeah, the data is very consistent that, for high-tech things, certain places, if you do it a lot, you get better at it.
Always.
Than dabbling in it. I think, like PCI, in terms of humility, so doing percutaneous coronary intervention for stable, not ACS, for stable disease.
Stable chest pain, angina, putting in a stent.
So, nothing can make more sense than I do a cath, I see a blockage, I'm going to open it. That is plumbing, it makes sense, it must work, right? Well, maybe not. We assumed it always works. It makes so much sense that, it made so much sense, we couldn't even study it in this country. You couldn't find cardiologists to randomize somebody to not get a stent. So they did an amazing study where they actually did, in Britain, I guess they can tell them what to do.
Communists.
A little bit more, right? So they randomized patients to get a cath and a stent for their stable angina, and another group got a cath. Only the lab people knew who got the stent or didn't. The follow-up doctors couldn't tell who got what. And they tested them on stress tests.
So it's like a sham cath.
A sham cath.
Yeah.
And they tested them on objective measures, subjective measures, and there was no difference between stent and no stent. For a stable angina, 1 vessel disease, failed medical management, and it was like...
And here's the thing, that stent causes problems in itself. You can have restenosis, you can have problems.
You have to
costs a ton of money.
You have to take double
the anticoagulant, Plavix. You cannot overstate this over-treatment problem in the US, and doctors get very triggered by this. Why? Because our incentives are to do things to people in our current system. We get paid for it, we were trained to do it, it makes sense, you're right, the plumbing all makes sense. But the truth is, like, you look at knee surgeries, you look at spine surgeries, you look at, most of the time a sham surgery is the same. Sham acupuncture is the same as regular acupuncture. What's going on? It's called the mind-body. People care about me, they're laying hands on me, they're doing something.
If taking a sugar pill could convince your mind that something good is happening, imagine surgery.
Oh, it's 12x.
I'm recovering from, look at the scar, I'm recovering, I can barely walk for a week. This must have been something good for me. And the irony is the FDA has a process for medicines to prove that they work. There isn't that for procedures. And so there was an editorial with that study that said, you know, this should change everything. Not every cardiologist agrees that this should change, that study should change everything. But they sort of made the case of, if it strikes you as perhaps unethical to randomize like sham surgery, well, isn't it even more unethical to have this procedure done millions and millions of times for years and years and years that may or may not be beneficial? I mean, that's, so, you know, a quicker way to get an answer would be the greater good.
One thing I like to tell my patients when I first admit them, you are now in the most dangerous place on earth. My job is to keep you safe and get you home safely and quickly and make sure we treat your problem. I'm going to be your ally in this. If you notice anything off, if you have questions, if you think something's not right, you need to tell us right away, or you need to have a family member or a friend here to watch your back, because it is hard, it's a complicated place. And this gets to the heart of we're doing things to people instead of necessarily for them. And if we can figure out that, you know, PCI for stable angina, one vessel disease, doesn't help, we should stop freaking doing it. And it's going to mean reconditioning a ton of cardiologists, particularly in the community. Sandeep Johar wrote a great book called Doctored, The Disillusionment of the American Physician. He's a Long Island cardiologist academic. His brother is a outpatient cardiologist, private practice. Their practices could not be more different, and across the street from each other. And the idea in the book, he talks about just constantly cathing people for GERD, doing treadmill stress echoes that are totally unnecessary, finding a little something on that, and then pursuing it. It's our incentives. As Robbie Pearl was on our show from Kaiser, and he said context determines behavior, and our context in this country is totally screwed up.
Absolutely, and you know, there is a, first of all, incentives work. I mean, that's for most 100%. Of the economy, for most of society, incentives work. So why should they not work here? Doesn't mean doctors are evil. It's just incentives matter. It's a hard sell to. Some of it, I think, is also people are just like, look, what I do for a living is important and it works. And it might be a tough sell to say, well, gee, maybe it doesn't work. And try explaining to the next patient with chest pain that they don't need a cath. I think it's almost like, you know, how it's easier to just give them the antibiotic than explain why they don't need an antibiotic. This is sort of like that. You know, it's just, okay, we'll do the cath because I don't want to sit here and then you'll go to another doctor anyway, he'll do it.
Because he'll do it. You'll always find someone who'll do it. Well, so I want to close us out because we're coming up on 37 minutes, and I want to get it under 40 so we can share this, because this is a fantastic discussion, man, and the comments are fantastic. Let's bring this back to the vaccine issue, because we've been talking about a lot about this lately. Vaccine issues where the science is settled, there is a lot of clear guideline and data, there's a schedule, we have the algorithm that works, and there's not a lot of variation in terms of how we ought to institute it. Now, the anti-vaccine guys and girls, they actually point out all the flaws in medicine that you and I are talking about. And so, in other words, that we're paid to do things to people, that their incentives do matter, that there's variation and we don't really know what's, sometimes something's harming. However, they go and take these correct instincts and truths and apply it to the one part of medicine where it doesn't apply.
It's funny, I promised my wife I wouldn't talk about the family, but I can't help myself. I'm not coming home till later tonight.
There you go, you're probably not coming home at all after this,
I'm in Vegas.
I know, let's go party.
You know, I was at a family dinner and somebody's new boyfriend was there and was anti-vaccine.
Good Lord. And
I against my better instincts, went into there and said, okay, let's talk about it. And it was like, either he thinks I'm an idiot, or, and I'm just saying the wrong thing and we're all just idiots, or there's this vast conspiracy going on. And what's worse, I'm not in it. You know, I'm the guy who didn't get the memo that this is, I'm like, they say it's
so you're even stupider.
So it's like, I would rather be insulted because you think the science is wrong, or because you think I'm not in on the right meetings to find out the vaccines are no good?
That's the thing. They keep saying we're getting kickbacks. I'm like, where?
Yeah,
Am I the only one not getting the memo?
Vaccines are the one area where you can't say it's done for the money.
Right.
For the most part.
Yeah.
You know, in fact, they have to have funds to protect the companies who do it, so they'll keep making
Exactly
it.
right.
Yeah.
We did a show on the vaccine injury court. We also did a show on the medical device and procedure FDA process, the 510K process. Yeah.
But for clinicians, I think the reason the vaccine guidelines are so clear is because the science is so clear. And I think good guidelines allow you to be firm where you can be firm, be flexible where you can be flexible, and have numbers, data, outcome that can demonstrate, to clinicians who are open-minded to change. Like, gee, maybe the care of CHF has changed over the past 20 years, and maybe something is different now.
I think that's a perfect way to end, because what you're basically saying in Z-Dog-ish is optimize 2.0 so we can transcend to 3.0. Love and care for your patients, and the way you do that is you do the right thing for them, transcendent of ego, and don't hate the guidelines if they can help. Now, do hate cookbook medicine because it's too extreme, and do hate full autonomy because you wouldn't want your pilot doing barrel rolls while another pilot's flying by the book.
A good example would be antibiotic stewardship programs.
Right.
So one area where docs have already been slapped and said, you are not allowed to prescribe vancomycin unless I say it's okay. And it happened, it went through. But I've never seen a Cochrane review that was praising the evidence for its efficacy. I mean, they were like falling over themselves saying, yes, this works. So that would be an example of where limiting autonomy is not always a bad thing.
Yeah, and you see, it feels onerous to the docs because you have to call for approval, but the truth is that's the only way. And as a resident, I remember I'm ready to drop the gorillacillin on this guy. Crap, I got to call ID. And then when you call ID, they say, so tell me what's going on. And suddenly you have this conversation where you got served, you got educated. You're like, I didn't realize.
In the beginning, as an intern, you're basically like, look, dude, I am just saying what the attending is saying.
The attending
I'm going to
wants
go back there and just yes or no.
He's going to read me.
Later on, you can actually have a clinical discussion. Where often, especially with the ID folks, they're like, do you know in our hospital, I'm like, I don't know. So,
And now I know.
So they were willing to give that up, I guess, because it's less threatening, but that was an area, a model of, it doesn't have to be threatening that some decisions you have to run by people.
I am all into what you're trying to do, Bill Rifkin, and if you guys want to learn more about what Bill's doing, what MCG's doing, click the link in the description of the thing. It's really, you're a Z-Packer too, man.
Yes.
Like you watch the show.
Yes.
So we were talking about Donald Hoffman and the nature of reality.
My wife was terrified that I'm going to be singing or something. I said, no.
Oh, should we do this right now?
It was bad enough that I was trying to pull off the pink here.
I think you nailed it.
She's like, really? You're gonna go to Vegas in pink?
I think you nailed it. That's the only way to come to Vegas. What happens here now goes out to everybody.
Now everybody knows.
That's right. So thanks, Bill Rifkin.
Thank you.
Thanks for coming out to Vegas. And guys, Z-Pack, I want you to hit like. I want you to hit share. I want you to tell the world about how we can build 3.0 by optimizing 2.0 and rejecting the worst aspects of 1.0 while preserving the heart of it, which is the human relationship. All right, guys, we are out.